Good evening, friends. Welcome you all for the second session on International Scientific web series on sleep medicine and update. After a successful first session on management of obstructive sleep apnea and phenotyping of obstructive sleep apnea, today we have with us an eminent faculty and an international speaker of repute, Professor Shahrokh Javaheri from USA. He will be he is a pioneer in the field of central sleep apnea management, and he will be speaking to us about the management of central sleep apnea. And to introduce our next speaker, we have Dr. Anukonda Sridhar. He is a medical director, Ajara Hospitals, Warangal, and who has got a special interest in management of sleep disorders. Over to you, sir, for the introduction of our next speaker, Professor Shahrokh Javaheri. Thank you.
Good evening, everybody. Today, our topic is central sleep apnea, management of central sleep apnea. Almost all sleep apnea is a underdiagnosed disease. In this, central sleep apnea is more underdiagnosed. Almost all less than 1% of world population is suffering with the central sleep apnea. Central sleep apnea is a heterogeneous group of sleep disorder breathing in which the respiratory effort is diminished or absent in a cyclical or intermittent fashion during the sleep. Most of the central sleep apneas are associated with the obstructive sleep apnea or underlying medical condition or narcotic overdoses or recent ascent to the high altitude. The primary central sleep apnea is very rare. The etiology of primary central sleep apnea is it is not known. With this brief introduction of sleep apnea, I will introduce today's speaker, Professor Shahrokh Javaheri. He is a sleep physician in Ohio State in Cincinnati. He is working at the Division of Pulmonary and Sleep Medicine, Bethesda, North Hospital, Cincinnati, and also adjunct professor of medicine, Division of Cardiology, in the Ohio State University, Ohio, and also working as an emeritus professor of medicine, Division of Pulmonary and Sleep Medicine in University of Cincinnati. With this brief introduction, today our guest speaker will deliver the topic on management of central sleep apnea. Thank you.
So thank you again for inviting me. And I thought today, as an introduction, we will talk about a number of disorders associated with central sleep apnea and touch upon how we treat them. This is a very important and hot topic, of course, in the United States and across the world. Next slide, please. These are my conflicts of interest, which I wanted to share with you. Next one, please. So the American Academy of Sleep Medicine classifies central sleep apnea into these 6 categories. But this is really, frankly, outdated, and it needs to be changed. And we are currently working on papers to try to update the classification of central sleep apneas. Next slide shows a little bit of the background here. Please show the next slide. So as you can see, we have a spectrum of disorders that can be associated with central sleep apnea. So for example, a number of cardiac disorders, which I will touch upon. The treatment emergent central sleep apnea is an important topic, of course. A number of drugs are associated with central sleep apnea, such as opioids. A disorder of endocrine, the acromegaly, has been associated with CSA. In the US, as well as in India, when people go on sojourn to high mountains, they're going to have a lot of central sleep apnea. In fact, OSA patients who go up there, OSA changes to CSA up in the high altitude. Then, of course, we have a number of disorders that are associated with hypercapnia and hypoventilation. And these individuals during a sleep can develop central sleep apnea. Furthermore, a number of central nervous system disorders, such as Chiari malformation and neurodegenerative disorders, can also be associated with CSA. Most recently, chronic renal failure in a number of subjects associated with both OSA and CSA, of course. And finally, when all the other causes of central sleep apnea are eliminated, we end up with idiopathic central sleep apnea. You can see there are a number of references here, and there are more to come. We are actually working on 2 or 3 more publications currently, which are under review. And I'll be glad to update you and send you references later on. Next one, please. Excuse me, I have some sore throat. So let's touch upon some of these disorders to begin with. A number of cardiovascular pathologies are associated with both obstructive and central sleep apnea. And in these disorders, we generally have a combination, a mix of obstructive and central sleep apnea, and sometimes one predominates, like CSA, and other times OSA predominates. But frequently, we have both OSA and CSA mixed together. So we're talking about left ventricular systolic and diastolic dysfunction, with or without heart failure, atrial fibrillation. Individuals with left atrial enlargement, now we see a number of patients in the US with left atrial enlargement that have central sleep apnea. Individuals with pacemaker also have a lot of central sleep apnea. Finally, chronic thromboembolic pulmonary hypertension. We had an abstract on this last year and another one coming up as well. As well as pulmonary arterial hypertension, we can see central sleep apnea in these individuals as well. So as you can see, a number of cardiovascular disorders could be associated with CSA. The important point here is that CSA is commonly comorbid with OSA. So the 2 phenotypes commonly exist together, and sometimes it's difficult to really tell which one is predominant, as we will talk about in a moment, in part because the hypopneas are very difficult to distinguish whether this is obstructive or central hypopnea, because we talk about central apnea hypopnea index or obstructive apnea hypopnea index, and the hypopnea part, the hypopnea component is very difficult to distinguish. Is it central or is it obstructive? And most of us will put the hypopnea in the obstructive apnea part, and that may or may not be correct, of course. Next slide, please. So this is a slide modified from our recent paper in the Journal of American College of Cardiology. So we have individuals, these are studies from all over the world, which I have summarized. So with the AHI of 15 or more per hour, OSA is in red and CSA is in green. You can see percentages on the y-axis, and if you look at the left ventricular systolic, this asymptomatic left ventricular systolic dysfunction, asymptomatic left ventricular diastolic dysfunction. So these are individuals that do not have heart failure, and on echo were found to have systolic or diastolic dysfunction. And you go to heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and acute diastolic heart failure. You can see really the prevalence of moderate to severe sleep apnea is huge in these individuals, 66%, 25%. In acute decompensated heart failure, these are subjects who are hospitalized for heart failure. 78% may have an AHI of 15 or more per hour. So this could be really a very important issue here, because if left untreated, they may contribute to rehospitalization and excess mortality eventually. So treatment is very important, and data suggests that in fact if you treat, you may help reduce readmission to the hospital, but RCTs are lacking. Next slide, please. Excuse me. I apologize. So this is a typical example of what is called Cheyne-Stokes breathing in patients with heart failure and reduced ejection fraction. You can see from the ECG, this patient is atrial fibrillation. And really, patients with heart failure and reduced ejection fraction who have AFib, almost 80% of them have central sleep apnea. The pattern is very, very crucial. This is a 10-minute epoch here. Each line is 30 seconds. You can see crescendo, decrescendo, central apnea. It's very, very regular. Each apnea is about 30 seconds in duration. So you can see how rhythmic this is. Very, very, really beautiful demonstration of the so-called Cheyne-Stokes breathing. Again, central apneas are of the same duration, which is a reflection of the how much the PCO2 drops below apneic threshold. The hyperventilation is here, of course. With the hyperventilation, PCO2 decreases, and therefore ventilation goes down. Eventually, central apnea occurs. With the central apnea, the PCO2 goes up. PCO2 goes up, PO2 decreases, so ventilation increases again. With increased ventilation, the reverse occurs. Ventilation decreases, central apnea, and keeps on and on and on and on and on. And there is oxygenation, deoxygenation, hypoxia, reoxygenation. So this system goes on and on and on. It is very easy to tell these are central apneas. You can see the thoracoabdominal excursions, the chest, abdomen, completely flat. And that is very critical, that you should look at the pressure probe, the temperature probe, the chest wall movement, which is a reflection of the intercostal muscles, and the abdominal, which is a reflection of diaphragmatic movement. All lines must be flat, completely flat. We do not agree with the American Academy of Sleep Medicine about the 90% drop. We say it should be completely flat to call it a central apnea, because otherwise it may be obstructive apnea. So in order to be 100% sure that you are dealing with a central apnea, we need 4 lines to be flat. Pressure probe, temperature probe, rib cage, and abdomen. All must be flat. And the pattern should be just like that. Next slide, please. So as I was saying to you, the hypopnea is a problem. So is it obstructive hypopnea or is it central hypopnea? This is an example of really a true central hypopnea, which we published in the American Journal quite some time ago. And the reason we are certain that this is a central hypopnea is because in this research individual, I have a balloon in the esophagus. And here is the balloon pressure in the chest, in the esophagus. You can see a gradually decreasing esophageal pressure and a gradually increasing, exactly like a pattern of Cheyne-Stokes breathing. And again, you can see the parallel changes in the airflow and the thoracoabdominal excursions. The most important thing is there's an arousal here. Your picture is on the arousal here. The arousal occurs at the peak of hyperventilation. That is where the arousal occurs. And this is in contrast to obstructive hypopnea. If it were obstructive hypopnea, the arousal would occur over here with a big breath. Here, the breathing gradually decreases, gradually increases. Arousal is at the peak of hyperventilation. This is not even mentioned in the American Academy of Sleep Medicine, which is a very important issue in distinguishing a central hypopnea from an obstructive hypopnea. So in any case, in a regular polysomnography, it is very difficult to distinguish them from each other. And frequently, we lump all the hypopneas together. We talk about central apnea index, obstructive apnea index, and the hypopnea index separately. But we always mention central apnea index because that is easy to differentiate from obstructive apnea index. Next slide, please. I just want to mention a few words about who actually discovered Cheyne-Stokes breathing. This is a very nice description of actually what happens, which is exactly what I showed you on the previous slide. Mr. Boyd suffered from gout, and he was called by a doctor, a family called this doctor to come to the bedside. And this doctor came to the bedside, and he noticed that Mr. Boyd was suffering from chronic irregularities of the heartbeat, which I think is atrial fibrillation. And as I mentioned to you, AFib is a major risk factor for central sleep apnea and heart failure. And as you can see here, very beautifully described, during the days before his death, he could not lie flat on the bed because he had orthopnea. He was suffocating. And he also had leg edema, which means probably he had biventricular failure. This is the best part of it. His breathing was very peculiar. This is the first description of the Cheyne-Stokes breathing. He would cease breathing for 20 or 30 seconds. As I showed you, really commonly it's a 30-second central apnea, and thus begin to breathe softly, gradually, which increased until the breathing extremely strong. At this point is where actually the hyperventilation, which becomes violent, and the person may wake up and actually snore at that point in time. And then again, gradually decreasing. So this is a beautiful demonstration. Next slide, please. What I just showed you. Yeah, so here is the violent breathing. At this point, in fact, the individual arouses, as I showed you on the previous slide. There's a snort. So you may hear a snorting, actually. But again, the breathing goes down, the central apnea, about 25, 30 seconds. Very beautiful demonstration. And next one, please. It happens that this man is not Cheyne. This man is a surgeon, John Hunter. This is the doctor that described Cheyne-Stokes breathing 40 years before Cheyne described it. And somehow Dr. Cheyne ignored Dr. Hunter's description. So the disorder is called Cheyne-Stokes breathing, but really it should be called Hunter Cheyne-Stokes breathing, which is what I refer to in my publications. Next slide, please. Yeah, so you can see it should really be called Hunter Cheyne-Stokes breathing, which is what I normally refer to. Next one, please. And here's the atrial fibrillation. So as I mentioned to you, this is a relationship with the chemoreception. With the central apnea or the hypopnea, PCO2 goes up, PO2 decreases. This stimulates the chemoreceptor, then the hyperventilation and the arousal. PCO2 goes down, PO2 goes up, the chemoreceptors are inhibited, then they cause central apnea, and the cycle returns and returns and returns. Goes on and on and on throughout the night. Next one, please. Now, is that the good tone, or is it too fast, too slow?
It's a perfect one, sir. Perfect.
Okay. Next one, please. So these are the a kind of an algorithm that discusses all options that you have for treatment of central sleep apnea in heart failure. Utmost is the pharmacological therapy of heart failure, because it has become clear that as you treat heart failure, central apnea improves, indicating that indeed heart failure is the cause of central sleep apnea. CRT has been shown that when CRT is done and heart failure improves, again, central sleep apnea improves. In fact, it is very interesting to note that the multiple studies on CRT indicate that when the CRT is placed, it is only the central sleep apnea that improves. OSA does not improve. So CRT works for central sleep apnea, but not for OSA, again indicating that it is the heart failure that is causing the central sleep apnea. And then, of course, we have adaptive servo ventilation, which we talk about in a moment. The CANPAP trial used CPAP. We have shown in a bigger study that cardiac transplantation actually eliminates central sleep apnea. Again, strongly suggesting that it is the heart failure that is causing central sleep apnea. So improvement in cardiac function by pharmacotherapy, by CRT, or by transplantation either improve or eliminate central sleep apnea, again indicating causation. Well, we have done a lot of work you may know about on pharyngeal nerve stimulation. We have now an $18 million grant from NIH, a randomized controlled trial on oxygen. So we have two groups of individuals with heart failure. One group will receive oxygen through a concentrator, and one group will receive just room air from a concentrator. So it's a double-blind, placebo-controlled study of 5 to 6 years duration. It has already started in the US, a 5-year to 6-year study, and the endpoints are hospitalization and or mortality. So this is an NIH-funded grant that is going on at this time in this country. As you all know, we have done randomized controlled trials with acetazolamide and theophylline, but no long-term study is available with these drugs. So the only long-term studies that we have are nocturnal oxygen therapy that is going on at this time. We have long-term studies on pharyngeal nerve stimulation. We have several publications on this. You may want to be looking to that. We have a long-term study on CPAP, and that was the CANPAP trial, and now ASV trial. So we're going to talk about the ASV trials in the next few slides, please. Next one, please. So as you recall, adaptive servo ventilation, as the name implies, this device adapts to the person's breathing pattern, and it is a servo, which means it's a negative feedback system, which means that when the patient has diminished ventilation, the negative feedback is such that the machine output increases. And when the person is hyperventilating, the device output decreases. So you can see the output of the device here. Look here, please. Here is the hypopnea. By the way, can you see the arrow?
Not, sir.
Oh, you don't see my arrow?
Yeah, I will follow it up.
Yeah, this is the arrow up here with the hypopnea in the green or blue. I'm sorry, the blue up here. Come on up here. Further up, 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 and to the right. Yeah, here 1, 2, 3, 4. The fourth column. The fourth column. Yeah, the fourth column, and the third from above. The third row. Yeah, and the fourth column. The third row from above. The third row from above. 1, 2, 3, and column number 4. Come on up, please. Yeah. Come on up one more. Yeah, that's the hypopnea. You see the hypopnea? Yeah, that's the hypopnea. At this time, as you can see, the device output in the very bottom increases. Down in the bottom. Yeah. And then when the patient hyperventilates, then the output goes down. Exactly. The output goes down. Exactly. Yeah, that's it. I can see your arrow, but you can't see mine, huh?
Yes, sir. Yeah, we are sharing the screen. That's why.
Yeah. Did you understand that?
Yes, sir. Yeah.
Okay. Next slide, please. So you can see this is, I'm sorry, go back, please. So as you can see, the device output is anti-cyclic to the patient's intrinsic breathing pattern. It is anti-cyclic. When the patient is hypoventilating, the device output increases. When the patient is hyperventilating, the device output decreases. So it is anti-cyclic. So it should be much more comfortable for a person to be on ASV than on a CPAP on a constant pressure. Because can you imagine the patient with Hunter Cheyne-Stokes breathing is hyperventilating a lot, and the CPAP is constant. That would be very difficult for the patient. With the ASV, when the patient is hyperventilating, the device output goes down. So it is much easier for the patient to breathe with this. And we showed in a meta-analysis that in fact, ASV was superior to CPAP as well as other modalities of therapy. So we expected an RCT to be performed to show a positive effect. Next slide, please. But as you all know, this was the Servo heart failure trial, which was published in New England Journal of Medicine by Covey and colleagues. And it was a randomized control trial of 60 months duration on the x-axis. what happened was, you can see gradually the blue line versus the green line. The blue line are the individuals on ASV. The green line in the lower line are the control subjects. As you can see from the beginning, time zero, there was a dissociation between the two lines. Actually, what was happening is more people on ASV were dying compared to the control. And it became significant at about 6 months. In fact, every year, there was 2.5% absolute increase in cardiovascular mortality in the ASV arm. So more people were dying prematurely on ASV compared to the control. This was actually similar to the CANPAP trial, which showed exactly the same thing, that more people died initially on CPAP than control, which was one reason ASV was developed and this study was done, but also this study showed excess mortality with ASV. So you can imagine now you are treating under-chain Stokes breathing and more people are dying in the treatment arm. It just that didn't make sense. So the authors, the investigators, Covey and colleagues, said, well, either central sleep apnea is compensatory to the heart failure, it should not be treated, or else the pressure of the device affected the cardiovascular system, and that may be causing the excess mortality. But let's just talk about that a little bit. Let's go to next slide. So we had, we wrote about this in great detail, and we said that the Servo heart failure, more questions than answers. We said that the problem was with the device. At least most of the problem was with the device. This ASV device that was used in the Servo heart failure trial had major problems with the algorithm, which we have discussed it in detail in this paper. And in fact, it is no more produced in the United States or anywhere else. I don't know if you still have that in India or not. The old device had major problems, and I think that was part of the problem. And what were the problems with the old device? Next slide, please. One of the problems was that in the ASV that they used in the Servo heart failure, the EPAP was fixed. In contrast to the new ASV devices that are made, that the EPAP is automatic. So in the course of this 16 months follow-up, about 40–50% of the patients converted from central apnea to obstructive apnea with the fixed EPAP. And I think that was a major problem because the device was not really effective, even though the investigator said ASV effectively treated sleep apnea based on the average AHI. So let's expand on that. What are we talking about here? The AHI at baseline was 31 and 80% central. That's what they said. And by 80% central, they are talking about central apnea hypopnea index. At 3 months, AHI average was 7, and it remained at 6 and 7 across the board. So the author said, yeah, ASV effectively treats central sleep apnea. But when you go to the supplement of the article in the New England Journal of Medicine, which is what I did, I found this. Wow, the AHI at the beginning had a range of 10 to 115. But as you can see, across the board, there were individuals who had a lot of residual AHI. Some people up to 72. 12 months, 51. Of course, some were treated effectively at 0, as you can see. But there were individuals with residual AHIs, which were primarily obstructive. And importantly, as you can see from the oxygenation, at baseline, 51 minutes below 90%, 51 minutes. At 3:12, if you go across, 20 to 25 minutes below 90% in average. So really, even in average, desaturation was not effectively treated. But most importantly is this range. So there are individuals on treatment who have 344 minutes below 90%. At 12 months, 268 minutes below 90%. At 24 months, 285 minutes below 90%. Even at the end of the study, 278 minutes below 90%. So the statement that ASV effectively treated sleep apnea is not a correct statement. Even though the average is fine, but there is a huge range. And we argue in the paper that we wrote, previous slide, please. We argued that the subjects who prematurely passed away, please next slide, either the pressure was wrong and they desaturated, and this is the subset that we believe prematurely, unfortunately, prematurely passed away. Next one, please. Yeah, and I want to show you the study by German cardiologists. This is a 10-year study, as you can see on the x-axis, and we have overall survival on the y-axis. These are 937 patients. These are people with heart failure followed by German cardiologists that were perfectly treated based on evidence-based medicine. And they were followed for 10 years. And what you can see, these 4 lines are the amount of time below 90%. And here are the quartiles. You can see 1.4 minutes, the black line, 1.4 to 12 minutes, the blue line, then 12 minutes to 52, the red line, and the green, more than 52 minutes below 90%. And you can see there's a dose-dependent relationship between mortality and desaturation. Again, survival is on the y-axis. So the more desaturation, the more premature mortality. And again, this is important because, again, in the SERV heart failure, there were a large number of individuals with desaturation. So we have asked the investigators to provide data, next slide please, to see really exactly what is going on with the data, because we need to see that there are individuals who use the device, who did not desaturate, whose AHI was less than 10 or 15 or 5, and compare this group to a comparable group in the control to see exactly what is going on with the device. Again, the other problem is that, of course, the average night usage was just only a few hours, and that doesn't work. So we need.
Sorry for the.
No problem. So we need a study to answer the questions. In fact, Dr. John Flores, who is a famous cardiologist, wrote to me, "Dear Shahrokh, I do hope that your thoughtful commentary in chest on the short failings of the SERV trial is widely read. And I hope that you all read this and really try to understand what I have said about." Next one, please. So at this point, then ASV should not be used to treat central sleep apnea and heart failure. We are waiting for the ADVENT trial, which is going on. I mentioned that we have a study on the phrenic nerve, and then most importantly, we have this trial now using oxygen in a double-blind study that if you invite me maybe 5 years from now, I can show you the data. Next slide, please. Excuse me. It's called loft heart failure. You can see. I presented these data in the memorial lecture of Dr. Thomas Petty, and I was honored with that presentation. in the last year in the American College of Chest Physicians. I don't know if any one of you attended the chest meeting in Orlando or not, and that was where I discussed the trial in detail. Next slide, please. Well, excuse me. I would like now to switch to TEXA, treatment emergent central sleep apnea. Initially, it was referred to as complex sleep apnea, and it was primarily reported with CPAP. This was a group of patients with OSA that were treated with CPAP, and they developed central sleep apnea on CPAP, and it was called by Thomas et al. Complex sleep apnea. Excuse me. What I want to emphasize that rather than using CPAP emergent central sleep apnea, excuse me, rather than using CPAP emergent central sleep apnea, we refer to it as treatment emergent central sleep apnea. And the reason is very simple. It has been shown many years ago that people with OSA who are treated with tracheostomy, they actually develop central sleep apnea after tracheostomy. Now we have seen reports of OSA patients treated with hypoglossal nerve stimulation that develop CSA with the hypoglossal nerve stimulation, with tongue retaining devices, with relief of nasal obstruction, with oral appliances, after tonsillectomy, after maxillofacial surgery, and even after Provent, the expiratory pressure relief. So it is really CPAP emergent treatment, emergent central sleep apnea, which occurs when we treat obstructive sleep apnea with any modality of therapy, be it surgery with tracheostomy, surgery with tonsillectomy, or maxillofacial surgery, or even oral appliances, and so on and so forth. So it is a disorder that comes about after treatment of OSA. And it is treatment independent, except that it is much more prevalent with CPAP than with other modalities of therapy. And probably with CPAP, it has to do with increased FRC and Herring-Bruin reflex, which further promotes central sleep apnea. Next slide, please. So the question is here, what should we do when you have an OSA patient who goes on CPAP and then develops CSA? Should we discontinue the CPAP? Should we go to ASV? Should we go to bilevel? Or should we tell the patient, listen, use the machine, it will go away? And the answer, my friend, is number 4. Next one, please. As you may know, here is our study number 1, 2, 3. Yeah. This was the largest study performed. We had 1,286 patients. Was published now in 2009 in Journal of American Academy of Sleep Medicine. 1,286 OSA patients that went on CPAP, and 6.5% developed CSA. These are full night polysomnographies and full night CPAP studies. It's not a split. And then what happened here? Can you see the slide?
Yes, sir, we can see it clearly.
Okay, so about 6 to 8 weeks later, we brought them back. Here's the follow-up PSG. On CPAP, we titrated them again. The same technique that we used initially, where we found 6.5% had complex sleep apnea. We titrated them again after the use of the device 4 to 6 to 8 weeks later. Only 2% now had so-called complex sleep apnea. So in most of them, it had gone away. And this 2%, almost half of them were on opioids. So there is only a very small subset of OSA patients that CSA, complex sleep apnea, CPAP, emergency central sleep apnea, there's only probably about 1% or so in our hand with correct CPAP titration that CSA persists after the use of the CPAP. I should emphasize that the pressure of the device at the follow-up was exactly the same on the night of the titration. So we got to the same pressure. So at the same pressure, the prevalence of the complex sleep apnea had decreased significantly after the use of the device. The same pressure, the same mask. And again, of the 2%, some were on opioids, which we're going to talk about. Now, if you can see, there are some characteristics on different studies. First of all, it appears that these are individuals with really severe obstructive sleep apnea. As you see, AHIs, all these studies are above 30. And in the studies that had a split, the prevalence was 15 to 20%. You can see the mixed, in this study by Lehman, some were split, some were not split. The two studies with the lowest prevalence were both full night PSGs and full night CPAP. So people with a split on the second half of the night have a lot more central sleep apnea than on the full night studies. That's the data suggestive of that. All right, next one, please. I don't want to discuss the mechanisms here, but this is a high loop problem, which is really a topic for an hour or another lecture in India, that what does high loop gain to do with a number of issues regarding sleep apnea. So as you can see, there was a randomized control trial by my colleague, Dr. Morgenthaler, a very important study by an important group of physicians in Mayo Clinic. This is an RCT. 66 OSA patients are randomized either to ASV or CPAP. It's a 90-day study, so there are about, 33 in each arm, something like that. And you can see at 3 months, at 90 days, those that were on ASV, 90% had AHI less than 10, whereas on CPAP, only 65% had AHI less than 10. So ASV was more effective than CPAP at 90 months for sure. But if you look at the residual AHI, what are we talking about? On ASV, it was 5 plus minus 8. On CPAP, it was 14 plus minus 21. Now, the authors say there was a statistically significant improvement in AHI, which is really correct. But we wrote an editorial, next slide please. We wrote an editorial on this, and so here are the ASV 33 patients, CPAP 33 patients. You can see, even though there was a difference in AHI, there was really no significant difference in Epworth Sleepiness Scale, quality of sleep, average daily use of the sleep, and how they got refreshed or not refreshed from sleep. There was no significant difference. So even though it's statistically significant, the difference clinically not significant. So if you can see from our editorial, here, by the way, down in the, I'm sorry, go back, you can't see the very bottom of the slide. The very bottom of the slide, down here should be a writing. I cannot see it. Can you see what's in the very bottom of this? Oh yeah, you see here? Oh, go back please, I just saw it. Now go back please. No, the same. Okay, well, next slide please. This slide, at the bottom of it is a writing, which I cannot see. Yeah, that's it. Hold this here, please. So there was no significant change in any of the quality of life measurements between the ASV and the CPAP group. Next slide, please. So in our editorial, we said that the data did not reveal clinically meaningful difference in AHI, 5 versus 14 in average, and thus one could question the clinical relevance of the findings based on the fact that secondary outcomes, including adherence, sleepiness, quality of life, and their feelings of their sleep, no significant difference between the two groups. So in our opinion then, CPAP, emergent central sleep apnea, is about 7% on full night studies, 6.5%. And after 6-8 weeks of CPAP use, it goes down to a couple percent. And the use of ASV may improve it, but there will be no change in quality of life and so on and so forth. So the question is, next slide, please. This is what I suggest. When should we go to ASV? This is somebody on CPAP, has used it. And what is happening is in follow-up, yeah, they cannot use the device. They remain symptomatic on CPAP because they continue to have moderate to severe sleep apnea. At this point in time, you have several choices. And of course, you could use as one alternative adaptive servo ventilation. Next slide, please. Okay, so that was the summary of CPAP, emergent central sleep apnea, or treatment emergent central sleep apnea. The point was that it is most common after CPAP, but can occur with oral appliance, tonsillectomy, Provent, surgeries of all kinds, but it normally should go away. In fact, if you recall, many years ago, we used tracheostomy to treat OSA. That was many years ago. Some of you were not born. And Glemino, for example, here at Stanford, unfortunately passed away, God be with him. He was one of the first people who showed it. It was another study from Italy, the same thing. So these are OSA patients. They were trached after the tracheostomy. They had polysomnography. They had central sleep apnea. Then a few weeks later, repeat polysomnography, CSA was eliminated. So our data on that I showed you on CPAP emergent CSA, very consistent with the tracheostomy studies, that normally it will go away. How much time do I have now, or should we stop here?
Sir, you can continue. There's no issue with the timings.
So let me, in the next few slides, let me talk about opioids. Is that a common problem in India?
Yes, sir, we see it very, especially for orthopedic patients. A lot of them are on opioids.
Right, right. Let me get a couple of minutes. My voice is not very good.
Yeah, no problem, sir. You can take your own time.
Of course, Afghanistan is a lot of opioids. And when I was growing up in Iran, we had a lot of opioids as well. And I remember you could buy it at the shop. And unfortunately, my own uncle, I think he had depression. He was 18 years old. He went to a shop in Shiraz, in Iran, and he bought opioids. There was no prescription needed, and he passed away with opioid toxicity, which is what I'm going to talk about now. If I have time in the next few slides, I will show you what is actually happening here. It is a very, very interesting issue here in the United States as well. So this is our study from 2014. These are a number of individuals on opioids that they referred to me. Actually, their symptomatology was snoring, witness apneas, daytime fatigue, and daytime sleepiness. And they were, the primary care physician thought that they are referring it to me because they have obstructive sleep apnea. And really, we didn't know about opioids and sleep apnea until we did polysomnography. And this is one of those studies. You can see here is a 10-minute epoch of a patient with on opioids. It is very, very interesting polysomnography, it is a challenge to score the study. The brain waves are really very, very strange. A lot of arousals that we have difficulty scoring it. This is the chin EMG here. So as you can see, chin EMG is elevated intermittently here at the peak of hyperventilation. Actually, you can see that's where the arousals occur, exactly like the Cheyne-Stokes breathing. Yeah, here is the hyperventilation. You can see this is the apnea here. Down here, apneas. Yeah, go across, please. Yeah, we can see the apneas, and then the hyperventilation is here. But look, this is a little bit different than the Cheyne-Stokes breathing I was showing you before. For example, you can see, look at this apnea. Let's see, 1, 2, 3, 4, 5. Column number 5, please. 1, 2, 3, 4, 5. I'll go to column number 5 with your arrow. Can you see? I don't see your arrow anymore.
Can you see it now, sir?
No. Oh, yeah, I can see. So you can see this apnea here. Can you see this apnea here? Yeah, you can see the apnea?
Yes.
Okay. Can you compare this to the previous epoch? Go back, please, to the previous epoch. Yeah, well, yeah, it doesn't matter, yeah. So you can see these apneas are of different duration. Can you see that?
Yes.
Yeah, and that's number one. These apneas are different duration. And number 2, if you go back to column number 5, again, where you were before, column number 5, please. 1, 2, 3, 4, 5. Go to number 5, yeah. You can see the apnea, please. Go back to the bottom, show the apnea, please. Use your arrow, please.
Yeah, it's.
I'm sorry?
Yeah, I'm using.
I don't see your arrow moving. I am on a conference call. Can I call you back? Bye-bye.
Can you see the arrow, sir?
I'm sorry?
Can you see the arrow?
No.
No?
Yeah, I see it now. Yeah, yeah. Move it to column number 5, where the apnea is, please.
Yes.
Go down, please. Yeah, you see, if you follow the apnea, the first breath that starts after the apnea, you see how big that is?
Yeah.
Yeah. Sometimes if you continue, sometimes it is not that big. Next apnea, the short apnea. And the first breath is small, but then bunch of big breaths. If you compare this pattern to the next slide, you see, this is really Hunter Cheyne-Stokes breathing. Apneas are the same duration. There is gradually increasing after the apnea. The first breath is small, and then it increases gradually. So the pattern is very, very distinct between the two, between the opioid and the Hunter Cheyne-Stokes breathing. This is heart failure. The other one is opioid. Next slide, please. Yeah, look, they are completely different. So a technician or a sleep doctor should be able to look at this and say, oh, this is not heart failure. This is not heart failure. This pattern is drugs, induced central apnea, or high altitude, a stroke, but not heart failure. The heart failure is unique, as you showed. Next slide, please. No, I mean the other way. Sorry. The heart failure, go back, please. This is what I'm talking about. This should be very, very distinct, and you should look at it and say, let me do an echo on this patient because I think this patient has heart failure. Next slide. You can look at the other one and say, either I am up on Himalayan, on the Everest, or I have opioids or some other drugs, or the patient has a stroke. This is the pattern. In fact, Dr. Severance, look here, when I published this paper, the reviewers asked me, can you actually tell what these events are, and asked me to put what I thought the events were, because it is very hard to distinguish them from each other. Is it really obstructive hypopnea? Is it central hypopnea? What is it? It's a very, very chaotic pattern of breathing, very difficult to score it. The events are difficult to score. Again, some are obstructive, some central, and extremely difficult. In contrast to the heart failure, it's very easy. Next one, please. So this is what I was talking about my uncle as well. Unfortunately, these individuals are found dead in bed. And in fact, in most cases, we cannot find any cause, except that there is opioid in the blood. And the cause of death could be either cardiac or sleep apnea, or a combination. Now, what people don't know about, next slide please, that unfortunately opioids not only can cause sleep apnea, but also they interfere with the K channel in the heart and can cause polymorphic ventricular tachycardia, torsade de pointe. Torsade de pointe. This is torsade de pointe, which can be caused by a number of drugs, including opioids. And it degenerates to ventricular fibrillation and cardiac death. So some of the people who die on opioids have torsade de pointe, and we have to be very careful. When opioids are given to individuals for whatever reason, what other drugs they are on that may combine with opioids and interfere with the K channel and can cause torsade de pointe. And that's a very, very important issue regarding the use of the opioids. Next one, please. So yeah, these are the drugs that we talk about that can cause opioids, and methadone is very notorious, as you can see here. Methadone is one of those major opioids that can cause torsade de pointe. Next slide, please. Yeah, and FDA has a black box about this. So people on opioids can, yeah, that's the FDA point regarding the QTC interval and opioids. Next one, please. So people on opioids may die during sleep, either cardiogenic with the arrhythmias, ventricular torsade de pointe, or respiratory depression with a terminal apnea, period. Next slide, please. Yeah, and you know, this is really amazing. This is the sale, the prescription of opioids in the United States. In 2012, I believe, there were 238 million prescriptions of opioids in this country, which is huge, unbelievable. Next one, please. So the treatment, of course, is important. Of course, the best treatment is to withdraw the opioids, if at all possible. But as you say, patients are given opioids after surgery. Unfortunately, a number of them become addicted. They keep using it, and it's very difficult to withdraw it. And then we have, of course, CPAP, ASV to treat. Drugs may help. There is a group of drugs, ampakine, which may be helpful, but again, we don't have RCTs. Next one, please. I want to show you that how, if you could withdraw the opioid, how much it's going to help. This is one single patient, a nurse in the ICU that carried a big patient, developed low back pain, went on opioids, came to us, and we performed the polysomnography. You can see very severe sleep apnea, AHI 64, primarily central apnea, you see at 30, and then CPAP didn't work, bilevel didn't work, ASV was very helpful, but she was depressed, she was intolerant to any device and did not use it. About a year or two later, she came off opioids. You can see here, the PSG now shows elimination of the disorder. So really, detoxification is a key to eliminate the central sleep apnea. Again, this really proves the causality. there are 4 studies of 4 patients, 2 with PSG, 2 with oximetry on opioids and off opioids, showing that if you take away the opioids, the central sleep apnea goes away. Again, showing the causality. This was published, we published this in 2017. Next slide, please. It's very difficult to get them off the opioids. So this is our ASV study that we did on these patients. So you can see on the x-axis, on the y-axis is the central apnea. On the ASV, down here, yeah, that's the AHI was, yeah, the 20 of them went on ASV, and you can see CAI decreased quite significantly, whereas on CPAP, CPAP number 1 and CPAP number 2, in most of them, central apnea has really persisted. So ASV appears to be the most effective therapy for opioid-induced central obstructive sleep apnea. But you have to really do a good titration on them with the EPAP as well as the pressure support to really get clear response to ASV. Next one, please. I think I'm going to stop here. Well, let me just mention to you a couple more slides how opioids actually cause sleep apnea. This is a part of the brain stem where we have the dorsal respiratory group, ventral respiratory group in here, and then there is a group of neurons, perhaps best seen on the next slide. The next one, please. Yeah, so here is the VRG group, ventral respiratory group. You can see very rostral cephalad is the Bossinger complex. And before that is a group of, in black, a group of neurons called pre-Bossinger complex. Down here, yeah, in the black, yeah. The pre-Bossinger, these are few neurons called pre-Bossinger complex. This is where we think the rhythm generation starts. So for the SA node of the heart, this is the SA node of the breathing, pre-Bossinger complex. So lesions of the complex can produce central sleep apnea. It's the rhythm generator. These are Feldman's study as well as some other studies. Next slide, please. And if you can see, for example, in rodents, you can put a needle exactly in the pro-Bossinger complex. You can see the pro-Bossinger complex. This is a needle that is placed, yeah, in the exactly. And you can infuse opioid just here. Or you can infuse naloxone just here, nowhere else. And the animal could be awake, go to sleep, or anesthetized. You can see first, if you could down here, artificial CSF, ACSF here. This is diaphragmatic EMG in the bottom, and you can see the breathing. Now, if you put opioids in over here, you can see the respiratory rate goes down significantly with Damgo. Yeah, Damgo is an opioid agonist. You can see that? Yeah. And you can see what is really happening. There is prolongation of expiration. Yeah. In other words, there is a long expiration, like a central apnea. And if you infuse now naloxone, which is an opioid antagonist, the breathing pattern reverses back to normal. Again, very nicely demonstrating that at the pre-Bossinger complex, you can put opioids, it can cause central apnea. You can put naloxone there, just there, nowhere else. It reverses it. Again, physiologically, pharmacologically, in animal models, that the pre-Bossinger complex is where the problem is. So when people take opioids, it crosses the blood-brain barrier, goes to pre-Bossinger complex, causes apnea, and of course, if they don't wake up, that's where they unfortunately pass away during a sleep.
Do you screen all patients with heart failure with a polysomnography for the presence of central sleep apnea, or do you triage these patients with heart failure who has symptoms related to sleep disordered breathing and then put them for a polysomnography to look for central sleep apnea?
Well, unfortunately, patients with central sleep apnea are frequently thin, do not snore unless they snort at the peak of hyperventilation. They don't have hypertension. They do not complain that much from being sleepy. So it is really an occult disorder, which accounts for underdiagnosis of the central sleep apnea. So unless you consecutively study patients with heart failure, they're going to be missed. In the LOFT heart failure trial, that we are doing in the United States, we are doing consecutive patients with heart failure because we know it is an occult disorder. So our paper that was published in the Annals of Internal Medicine in 1995, which is what, almost more than 20 years ago now, we called it occult sleep disorder because what we found, and that was consecutive patients with heart failure. We will go to the clinic and enroll consecutive patients. And what we found was amazing. There was no difference in symptomatology between patients with no sleep apnea versus severe central sleep apnea. And unless we had done this study, we would not have known it, which the title of the paper reads, Occult Sleep Disorder Breathing. So the answer is, if you don't do consecutive patients, they're going to be missed.
And
because there are no difference in symptoms, whether you have it or you don't have it. The mechanism, the reasons is this. The symptoms of heart failure are essentially identical to symptoms of sleep apnea. Look, heart failure patients, they're fatigued. During the night, they cough. They have PND, orthopnea, wake up to urinate. They're on diuretics and this and that, beta blockers. So the night they are waking up to urinate, they're coughing, they have PND. Is the PND the hyperventilation of the Hunter chain Stokes breathing, or is it really just a PND? Is the orthopnea when they lay down, go to sleep, is it really, the sleep apnea, or is it just the heart failure itself? Overlapping symptomatology, and therefore they can't tell, we can't tell unless we do this study. Is this heart failure patient just heart failure, or the symptoms are in part related to sleep apnea? So that is the problem. However, about 2 years ago, we published a study that when we took consecutive patients with sleep apnea, heart failure, you do the MSLT. Now it becomes obvious that indeed patients with heart failure and sleep apnea do have objective daytime sleepiness compared to subjects with heart failure without sleep apnea. Even though the Epworth is the same, objectively now it shows that if you have sleep apnea, you're going to have daytime sleepiness in spite of similar Epworth. Very interesting.
And how effective do you think, sir, like when you treat a patient with a heart failure with a central sleep apnea, how effective it will bring about a change in their symptoms and their performance during the daytime? Like what is...
So with the ASV and CPAP trials, there was not a lot of difference. In our paper on acetazole, so with the pressure therapy, it appears there's no significant difference. With phrenic nerve stimulation, now we have several publications, if you look up my name, under phrenic nerve, which is a unilateral stimulation of the phrenic nerve. There is improvement in Epworth and quality of life. With acetazolamide, in our American Journal of Respiratory Critical Care Medicine paper, a randomized control trial, there is improvement. So there is a difference between mask therapy versus non-mask therapy. That with non-mask therapy, there appears to be improvement. With the mask therapy, there appears to be no significant improvement, which is also very interesting.
And another thing, sir, you have already explained in your lecture, like it's a big topic on its own, the concept of the loop gain and the, so I think I will catch you up in the next lecture. I think you will be the best person to explain the loop gain and the plant gain and the control.
Absolutely.
And one more thing, sir, what benefit do you think with the upcoming of the Advent HF? What is the modification in the study design, which you think will impact the outcome of Advent HF?
Right.
In comparison to
Right. So the Advent trial is using the upgraded ASV, which means that the EPAP is automatic. Which is a major difference. Of course, the Advent trial is using the Respironics ASV, which is a flow-dependent device, rather than the minute ventilation device that is the ResMed device. But the most important difference, of course, the two important differences are it's a flow. It works on the flow algorithm, and the EPAP is not fixed. But, you know, unfortunately, so far in this trial, 60–70% are heart failure with OSA and only 20–30% with CSA. So its impact is really unclear. If it turns out that it shows improved survival, the power is not enough for CSA, because only 20–30% have CSA. And then I would argue, if I would write an editorial on it, I would argue that, well, 70% had OSA, and I'm not going to treat them with ASV. I'm going to go first with CPAP. So its impact, I can predict, as I just told you, it is not going to solve the problem. So what we really need is a trial for the kind we are doing for the left heart failure, only for CSA, to be powered enough to answer the question. So the Advent trial, I hope it shows improved survival, but its implication is questionable. Again, for the CSA, it's not powered enough. And if it's OSA improved survival, we would say, insurance companies will also say the same thing. Well, use CPAP first. Why should you go to ASV, which is much more expensive? So that would be the editorial I would write on it once it comes out.
Thanks a lot, sir. It has been a very enlightening session for all of us. We have more questions, more doubts, and your topic, in fact, triggered in us more doubts, which we have to put into clinical practice to see the results. And we are ever grateful for you for readily accepting our invite to be a part of this lecture series. And we will hope to meet you soon in person in conference. And we would like to learn a lot from you as well.
Thank you. Thank you so much. It is my honor, first of all, to see you and share my thoughts with my colleagues in India. We are from the same region, and it's always, I was the honorary lecturer at the Indian Sleep Society last or 2 years ago in the US. I think it was in Boston. I don't know if you were there or not.
No, sir, back then I wasn't there.
Oh, you wasn't there. Okay. So it's always really a pleasure for me to discuss my thoughts and share my thoughts with my Indian colleagues. What I would love to see, I was in India a few years ago in New Delhi, and it was a fantastic trip. If there was an occasion to see Mumbai, I would love to travel there and give some lectures over there as well. So that would be, of course, after the COVID goes away. And if there's an occasion, I would love to do that as well.
If not for COVID, we were planning once with the routine meet lecture series. I was about to invite you down to India as well. But before
Thank you so much.
COVID, so we thought we shouldn't lose the opportunity to at least teach the people on a web platform.
Absolutely, yeah. There are so many topics really to discuss, which this field is really beautiful field, and it really is now in embryonic state, because all these trials, like ASV trial, failed. The SAFE trial for the CPAP failed. So we really need good trials to really look exactly what is going on. And I don't know if you had the opportunity to read my paper in CHEST, which I wrote about the SAFE trial and why that failed. That was OSA, because that would be another topic, an hour topic, just an hour topic at least for OSA, why the SAFE trial failed.
Yeah.
So anyway, we'll be in touch. We'll be in touch. You've been so nice to write to me and invite me, and it was, as I say, I feel it is my honor to be with you and share my thoughts with the colleagues.
Thanks a lot, sir. Thank you. So grateful to you.
Thank you so much.
Opportunity.